I would like to invite Dr. Randeep Singh for moderation. He's medical oncologist from Delhi.
Thank you. Am I audible and the slides are visible?
Yes, sir.
Yes, Dr. Randeep, your slides are visible, you are also visible.
So, now I would
And
like to introduce the panelists. Dr. Vinayak V. Maka from Bangalore, Dr. Mohit Sharma from Delhi, Dr. Vimal Pandita from Dehradun, Dr. Rajiv Saini from Jammu, Dr. Bipnish Sansar from Varanasi.
okay, and I hope that everyone is available. And thanks to the organizers for inviting me to this discussion. And thanks for the
Sir,
panel experts and dear colleagues. Yes,
Dr.
tell me.
Vimal Pandita is not yet there.
Okay. And I would request if any speakers are there who have presented their paper, they can also definitely pitch in. And a very warm Saturday evening to everyone. And I think all the experts for today's discussion will agree that there are quite exciting abstracts which the organizers have chosen. And I shall congratulate the team, Kumar sir, Vanita ma'am, as well as others, that actually in this session, we have around 40 minutes and the abstracts are actually quite encouraging, though the numbers are very less. So we will start with the first one, and that is about HER2 positive lung cancer. And there are two abstracts on them. First is about first line HER2 positive lung cancer patient, and the second is about someone who's progressing on TKI. And here the TKI in Pramio's paper is about osimertinib. So I think anyone, we have around 5 or 4 panelists, and it is a small house. Anyone can pitch in. I have not dedicated the questions to anyone, and we can take one by one since we have time. So HER2 example. So once we have a HER2 mutation in lung cancer, or we have a 20 mutation in lung cancer, do we differentiate these three things? Anyone can take this. There's some background noise. Yes, sir, that is better. So anyone, so once you have a HER2 mutation, suppose we talk about a HER2 mutation, do we really differentiate as of today whether it is what type of mutation is there in HER2 or in exon 20? I mean, what thing we are dealing with, and does it matter to us uh, with respect to the treatment or prognosis? Anyone can take it. Vinayak, you can start with this.
Yeah,
Yes.
I think we are evolved to target HER2 now in our front line. I don't know how the due approval has come or not. I have not seen a single case of HER2 positive in my practice. I religiously do it since almost 2 years. What we have learned is that the mutation profile and the response are different, and we expect
So
more.
Vinayak, I'll stop you here and ask you, once you do a RT-PCR, they cover the exon 20. So even if you are most of the, I mean, how you are testing your EGFR?
So I'm asking for broad-based NGS.
If you're asking for broad-based NGS, then HER2 is being covered. Even if you don't want, it comes up.
Yeah,
That
it's
is
not
one
come
thing.
positive. It's not come positive. That's my grievance.
And second was, are you checking for a particular HER2 IHC or a fish?
As of now, I'm not doing IHF fish as of now
Okay. And
because the
anyone among
cost
the
will
panelists? Okay, Vinayak, anyone among the panelists who is particularly checking for a HER2 at diagnosis, apart from broad-based NGS which we are sending, or a broad-based RT-PCR where exon 20 is being covered? Anyone who is checking for HER2 by IHC or HER2 by fish?
Dr. Randeep, as such, right now we are not checking for specifically for HER2 mutations, but yes, as compared to the HER2
So I'm talking about
amplification
amplification. I
or
am very specific.
overexpression, the
Sorry.
HER2 mutation, especially the HER2 exon 20 mutation, they are emerging as the most clear targetable driver of for the HER2 directed therapies. So
Okay. So
the
can you
point
please
mutations
identify?
are.
Is it Rajiv?
I'm Mohit.
Yes, sir.
No. Who was there? Sorry, I could not
I'm
take the
Mohit.
comment. Okay, Mohit. So you are not checking for amplification. Anyone who is checking, Rajiv, I mean, particularly I'm talking about fish. So I'm being very specific in this question.
No, sir. We are not checking HER2 by fish.
Okay. Anyone from TMH is there? Vanita ma'am, are we checking particularly HER2 by fish to rule out the amplification? Or anyone from the TMH? I could hear some.
Randeep, sorry, I'm here, Randeep. No, we aren't checking it. We are checking it as part of a broad panel testing.
Okay, ma'am. Fine, fine. So I will just proceed further. Thanks for that comment. I wanted that comment particularly. So we know that once we talk about the exon 20 insertion, as Vinayak said, yes, we are seeing it less, but it comes up even if you're doing a broad-based RT-PCR or no. And now you're doing more of NGS, these things are coming up. When we talk about insertion, we have these two drugs, and yes, they are approved, amivantamab and mobocertinib, and amivantamab trials are going on at 5-6 centers within India, particularly about combination of amivantamab and chemotherapy in the first line exon 20 insertion. This is a particular thing, and this is the most common abnormality which we see in the exon 20 domain. Apart from that, definitely we have point mutations. And a question to the panelist is that when do we differentiate? So we are not checking for amplification. That question is out. Now talking about point mutations and 20 insertions, are we treating them separately? Now anyone can take this question. So mobocertinib and amivantamab are particularly for exon 20 insertions. If you have not an exon 20 insertion, you have a point mutation. Is there any other drug which we are using, or how are we treating as of today? Because we don't have access to amivantamab outside the clinical trial.
Dr. Randeep, Dr. Mohit here. I guess we have limited data for TDM1 and trastuzumab deruxtecan, if I'm not wrong.
So how will you treat in today's practice? Suppose the thing crops up. You have the report in front of you, you have an exon 20 insertion, and another patient is there, you have an exon 20 mutation. Would you treat them both alike, or would you treat them separately? And with what you will treat apart from chemotherapy, suppose. Of course, there is a blanket answer of chemotherapy, which we do, all of us. Would you like to do anything else? Would you like to give first line TDM1, Mohit?
I'm not sure because I don't have any robust data for that. But yes, as per the literature, I have data only for TDM1 or trastuzumab and the deruxtecan.
Perfectly
That's
right.
it.
Perfectly right. Okay, Vipnesh, exon 20 insertion or mutation, both of them. Would you like to give both of them amivantamab or refer to a trial, or you would like to give both of them TDM1, or would you like to treat separately?
And with the available data, TDM1 will be a good choice.
TDM will be a good choice. And would you like to differentiate between HER2 mutation and exon 20 insertion? Because TDM1 data is more about HER2 mutations and it is less about exon 20 insertions.
So more in the HER2 mutations, TDM1.
Okay. So now we come to the trial and see how we can use this in practice. I think in one word I can summarize for all of us is that this is Cleopatra lung. And we have a very good experience of giving the regimen in females with breast cancer. So we will not talk about the efficacy, we will just talk about the trial data. Before I go to this trial, I would like to just go behind and so what we can have best is deruxtecan, we will all agree. And the deruxtecan gives you a response rates of around, if you see the last row, the maximum response rates are with deruxtecan in mutations, which are 60 to 70%. And they're actually very good. If you ask 60-70% response rates are really very good number, especially if you concentrate on the population, which is the third row. They are all heavily pretreated patients with 4-5 lines of therapy. And the median PFS is around 13 to 14 months or 10 months, 12 months. So that is I can say a benchmark which we can compare this trial. Okay. And now we go to the results of this trial, which was shown by the speaker. I think Dr. Prabhat had presented. And the response rates are 28%. No, someone else has presented this, and the median PFS is 6 months. So now we don't have access to amivantamab and we don't have access to deruxtecan. So do you agree?
Vijay,
Yes.
I'll just,
Vijay, yes,
this is just for knowledge. Tata
the
has
trial for deruxtecan, another trial.
amivantamab trial is going on in Tata. So if anyone wants to refer exon 20, we are open at Tata for the trial.
Vijay, I did mention that there is a trial, but I think that is a first line trial of amivantamab with chemo, or it is later lines also.
So we have both trials. We have the first line trial also and later trial also.
And you are including only exon 20 insertions or HER2 mutations?
Amivantamab trial has only exon 20. It's by the name Papillon. It's only for exon 20 insertions.
Perfectly. So this you have already cleared.
right?
Yeah, yes, ma'am.
Yes, ma'am.
EGFR exon 20.
EGFR exon 20, not HER2.
No.
Yes, EGFR exon 20. Perfectly. So that is what HER2 mutations are not there in amivantamab, and that is what I was trying to bring out from the discussion also, that we have to treat these two separately. And I have already taken comment from ma'am, and I agree that we are not doing amplifications as of now, because the data is very, very fishy if you talk about amplifications. Yes, as of today in India, if you can access the trial, I think this is the best data set. Coming to the study which was presented, and that is the point of discussion. And now I come back to my panelist. How do you fit this with the discussion of last 6-7 minutes? How do you fit this data set? Are you happy to use this? Because you also have access to TDM1. And let us forget about exon 20 insertion. Though in this trial set, both the data sets were there, exon 20 insertions and point mutations. So anyone, would you be happy using this regimen, Cleopatra lung, exon 20 mutation, point mutations? Let's make it simple. Or you are not happy and you would like to use TDM1 or afatinib or chemotherapy alone?
I think Randeep, either option is good. If fitness is performance status are not an issue, and usually the performance status is an issue in lung cancer when compared to breast cancer. If you take it, TCH itself is a difficulty in breast cancer patient with comorbidities and everything. I would see the patient performance status and assess it. The data is good. If you're speaking scientifically, this data is good to do. It's very tough to do with patient profile. Otherwise, I would be comfortable to do.
Okay. Anyone else would like to comment? Any of the panelists, Rajiv, Mohit, Vipnesh, to put the things in perspective. I mean, we have already discussed, and this is a trial which was presented at ASCO and discussed in the session also. So fine. So I think we will proceed further. I will conclude that yes, as Vijay was mentioning, I would be very happy if amivantamab is available 20 insertion. Coming to mutations, still we don't have deruxtecan available to us, and the trial will be soon out in India also. I will be first tempted more to use TDM1 because of the data set and tolerability, as Vinayak mentioned. And yes, I am open to use this, but with the caveat that this is a small number and the response rates are encouraging, but the PFS is not very encouraging to my mind. So that is my take. I think I had allotted 10-12 minutes to this. Second is also very interesting, osimertinib resistance. That is a Tramios trial. Before going to the trial, I would like to ask my panelist, how do we treat osimertinib resistance mutation negative as of today? Monday morning, Saturday evening, we are enjoying. We will be finishing our Saturday day work. Monday morning, osimertinib resistance happens. We send an NGS, no mutations. How do we proceed? And then what we can do for the future? I mean, so first, as of today, what are we doing?
I think you're rightly. I think we do NGS. It's very difficult to convince patients for resistance pathway, but we are sending as of now.
Yes, Vinayak, I will stop you here. NGS done, no mutations. I put in the heading.
I know. So our standard practice is still chemotherapy. This is exciting. Academically, yeah, it's looks, but still I'm not very convinced with the. It's like wild type you're doing something differently, so I'm not very much convinced. But patient profile doesn't suit in my practice.
Okay. Anyone else? Yes, sir.
If the patient, yes, sir. Sir, it depends upon the type of progression. If the patient has florid progression or if the patient has limited progression, in that
Rajiv, I will stop you here. Florid symptomatic progression, radiologically symptomatically, osimertinib resistance.
Then, sir, I'll tend to treat patient with the chemotherapy only.
Chemotherapy and atezo bev paclitaxel or chemo plus bev or chemo?
Sir, only chemo.
Only
chemo plus I can add bevacizumab also.
But why not atezolizumab if someone is affording?
Sir, data is still not very convincing.
I mean, we have only one data set which speaks quite. So when you would put this patient on immunotherapy, third line or never? And then if I talk to you about putting on single agent immunotherapy, then the data is further down the lane as compared to atezo bev paclitaxel.
Yes, sir.
Okay. So where does this trial fit in? Before this, anyone would like to? I will just show you 2-3 slides and then we'll come back to this paper. So what is happening is quite exciting. Someone who is really deep in lung cancer. This is a trial called amivantamab plus lazertinib. Amivantamab, we all know the drug. Lazertinib is a EGFR third generation, something like osimertinib, irreversible TKI, acting in the brain and outside. And what is exciting is that irrespective of, if you see the inclusion criteria, these are patients who are progressing on osimertinib, And if you don't have any mutation, also this regimen is working. This trial is in that it's a phase 1 trial. And if you see the results, they are quite encouraging. On the right hand side, the response rates are 36%, PFS is 4.9 months. And another drug, patritumab deruxtecan, this is another ADC. It is a brother sister of trastuzumab deruxtecan, which is a HER3 DXd called as. Again, this is irrespective of your mutation status, someone who's progressing on both EGFR TKI plus chemo or OC plus chemo. And the response rates are 40% with a median PFS of 8 months. So this is what is there lies in the future clinical trials. And now coming to Tramios. We have already heard the results. The results are there on the right hand side. Would you use this regimen? Considering, of course, we go for chemo. In future, we have access. We put them on patients on amivantamab plus combinations. Now here we are standing. Anyone would like to use TDM1 plus osimertinib?
So Dr. Randeep,
Yes.
so Monday morning, I think you are going to confuse all of us. Whether we should treat the patient or we should look for anybody is doing any clinical trial in any of the center. So
So right
please
now we
everyone,
don't have-
I appeal everyone that post wherever your centers you are doing clinical trials. Because now life has become easier. Now we understood that now osimertinib is the first line of treatment. Now there are so many things and combination and all the pizzas coming up with amivantamab and combination with lazertinib. So actually Monday morning is going to be difficult for all of us. Rather than easier.
Fine, I agree. So I think, to my mind, if I have to put, because Kadcyla or the generic version is available, I'm not happy with the results. That is my take. And I would, anyone, because yes, only one thing exciting which I found was the response rate happening in HER2 plus from this trial. That was actually exciting, that someone who's having HER2 plus is also having some control of the disease. That is what I found, which was exciting. And this is not like HER2 we treat in breast. HER2 is very different in lung. And I will not be happy to put them on TDM1 osimertinib. My choice will be chemo with BEV or chemo with BEV with immuno if someone can really afford and fit enough to undergo the ABCP regimen. So I think we will go to the next part. If there are any comments from the panelists or experts regarding these two trials, else we can proceed to the next one.
Dr. Randeep, Kadcyla's
Yes.
randomized study again will start in Tata in around 2 to 3 months. It's under
The
NIC
challenge,
approval.
this one.
Yeah, post
The
osimertinib failure, the combination for amivantamab lazertinib is the phase 3 study.
Okay, wow, great. I think Vijay, you should put it in some groups or social groups here. Seriously,
I'll
I mean,
do that.
it's a
I'll do
serious
that,
comment. You are, I know you have been busy, but I mean, a single message will really help patients and every one of us. If you can put it on a social media or through some way, a message can be flashed. Now that will be really helpful.
Yeah, I'll do that. Unfortunately, to put in social media, I need to take IC permission. I have already applied for that.
Oh, okay. And once the trial is running, then or you can just put a message. I'm not asking for a. I mean, I understand under the limitations. Fine. Once the trial is on.
So Dr. Randeep, one query and one clarification.
Yes,
so
sir.
I always know
Very
used to
quick,
confuse.
very quick comment.
Yeah, I used to always get confused in the beginning about HER2 exon 20 and the EGFR exon 20, because if you look at the EGFR exon 20, the amivantamab is going to cover that mutation, but not the HER2 20 mutation, where there are so many drugs, obocertinib and poziotinib and pyrotinib. These are the drugs. So that is one point. I used to.
Vanita, ma'am, can you clear that? Ma'am was mentioning about EGFR and HER2.
Sir, I think as Bharat had said.
Yes, ma'am.
Yeah. No, as Bharat had said, so initially the drugs were developed for both together, but then we found out that they are quite different. And poziotinib or some of the other drugs work better for HER2 exon 20, but don't work so well for EGFR exon 20. So they are different. They are very close together, but they are different, and they are different drugs. We don't have access to any of those drugs. So actually, I guess discussing all of that doesn't matter. Ultimately, in the end, we'll treat them with ABCP or chemotherapy. But yeah, there is a subtle difference.
Thank you, ma'am. Thanks for the expert comment. I think we will progress. We will go to the next two sets of discussions. This is about ROS1 mutation. Unfortunately, all of them are very rare mutations, but they are very interesting as per the discussion. And I would also request the organizers to let me know 10 minutes prior. Please interrupt me 10 minutes prior so that we are able to cover
10
everything.
minutes are now, sir.
Only 10 minutes are left.
Yeah, we have that oration, sir, after this. So, yeah.
Okay, so that is at 4, huh? No, it's at 4 o'clock. Now we have 20 minutes.
Okay, sir. Yes, sir.
No, just let me know.
Yeah.
So we have 20 minutes, 10 minutes for ROS and 10 minutes for NRG. Okay,
Yeah,
done.
okay. Okay, sir.
Okay. So second is about these two trials. These are again interesting. One is about resistance mechanism to crizotinib and lorlatinib, and the second was about entrectinib. And we will first start with this slide. The first line agent, what do we prefer in our practice? We have 3 drugs available. With approvals are crizotinib and entrectinib. We can see similar response rates and a similar PFS. So how do you decide if both the drugs are available to you as of today? We have crizo, life is simple, and serotinib. But tomorrow, if we have entrectinib available, how do you choose which is the best agent?
If in case of if we don't have any brain mets, so crizotinib is easily accessible, so I'll prefer crizotinib. And in case the patient has brain mets, then crizotinib is not crossing blood-brain barrier. In that case, I'll prefer serotinib, or in case entrectinib is available in future.
Perfectly. I think that you have summarized this very well, that CNS metastasis, we would like to give entrectinib. Just a question, if you have a CNS mets upfront with ROS1 positive, what would you do? You will give radiotherapy with crizotinib, or you would like to hold brain RT and try your luck with crizo?
I think I'll give a whole brain RT along with crizo.
Or an SRS with crizo. I mean, cyberknife or SRS with crizo. Okay, so that is the major difference between crizo and entrectinib. And as of now, we have lorlatinib approval for the second line. So that is the basics which we have there. And this is this is from the same paper which was presented about. I think this is the first. I think. So this was about entrectinib paper only, and if you can see, yes, this is from the entrectinib paper which was presented. If you see the data set, it is quite, encouraging that whether you have CNS mets or you don't have CNS mets, entrectinib has a good response rate. It is something like an Aussie with EGFR. Your median PFS is 11.8 months with baseline CNS mets and 19 months with no baseline CNS mets. And your overall survival is quite encouraging of 29 months with CNS metastasis, showing that entrectinib has a very good activity for brain metastasis patient. And now, once you have started the patient on crizo, why I have written crizo here, because that is more what we are doing. All of us are doing this only. And we have the second paper where very beautifully the mutations were discussed, and that is one of the largest data set in the literature which is available, which was chosen and discussed in this session. Now, to be frank here, I have read the paper, but I don't have experience with these mutations. Can the panelists help that? Are they someone who is failing on crizo with ROS? To my understanding, it was that we can put them directly on lorlatinib, which is available to us. But are we sending the NGS? And here we can take help of the experts first. Suppose someone has progressed on crizotinib. Again, this is not a CNS progression. It is not a oligo progression. It is a symptomatic multi-site progression, radiological and symptomatic. So how are we dealing with it?
Sir,
yes.
Yes, it is better to send the NGS because around half of the patients have a mutation in the ROS1 and other half have amplification in other pathways. So NGS will detect both the mutation which has caused the resistance, and also the other any pathway that can be targeted.
So what will you do, Bipinesh? Tomorrow someone is progressing on crizotinib and you need to start the therapy next line. You will put them on lorlatinib or you will send the NGS now?
I'll convince them to get a biopsy and NGS. If they are not willing, then definitely lorlatinib is the option.
Okay. And anyone else would like to comment before?
Yes, one comment is there. Since ROS1 patients, they have better response to pemetrexed because of limited transcripts of the thymidine synthetase. So I think we can also think of putting the patients on pemetrexed, especially if the patient is on crisis.
I agree with you, and I understand why you are saying this thing is because of this chart. And this was the similar charts we used to see when the second, third generation ALK inhibitors were developing, akin to what Dr. Anjana said, that akin to CML. And so once you see this chart, I will just run through it very fast. One of the best drug which seems, as per this chart, again, this is the chart of IC50, and this is the chart which has been derived in the cell lines. This is not a in vivo thing, it is an in vitro thing. But yes, this is what is available from the paper, that in the cell lines they have used these ALK inhibitors, and to your surprise, alectinib was one which is having no ROS activity, I mean, absolutely no ROS activity. And cabozantinib is one which acts against most of the, we are of course talking about ROS dependent mechanisms here. Someone who has a ROS independent or non-ROS kinase domain mutations like neurofibro, NF1 activation, MET amplification, or HER2 coming in, those we are not discussing. Now, once this chart is available to you, how will you use this chart and what you will do? Tomorrow, suppose someone has progressed on Chryso, I send an NGS and I have a mutation available. Vinayak, what would you do now? Would you consider this paper and
Actually,
consider?
now that the drug is available and drug is showing the best response, consider. I'm not doing NGS for post progression as of now, ROS as of now, but ROS are much better than ALK. They have very good profile. Patients they're living long. It's worth it. I mean, the drug is within the reach. I would use this chart. I mean, this is my learning for the day at this meeting.
So you would put them on lorlatinib or no after seeing this chart. Though this is a preclinical, but yes, there are other data. There are actually in the literature data set suggesting this chart also. It is not that this is the only one paper or only one of the first where they are being reported. There are many case reports and case series where these mutations are being discussed in the literature.
Yeah, this chart would help us actually to choose an agent which will.
Anyone would from the panelist or from the house. So I thought I have just, this is to my mind that if you have a ROS1, we start them on Chryso. Most of us are doing this because entrectinib is not available. If you have an oligo progression, we will try to give radiation and then put them back on Chryso. If we do an NGS and you have G2032R, which is the third row from up, I think we can put them, repotrectinib is not available, so we will put them on cabozantinib. If you have non-G2032R and we can see this, if someone is sensitive, I can put them on lorlatinib, or to be on the safer side, we can also consider cabozantinib, whether it is a G2032R or non-G2032R. G2032R is the commonest mutation among the ROS-dependent mechanisms, whether the patient is on Chryso or lorlatinib. So this is to end. I mean, any comments, any suggestions before we go to the next data set?
Randeep, anyone has experience with cabozantinib on post first line ROS treatment?
We can. I mean, I can reiterate your question. Anyone has experience of using cabozantinib in a ROS1 second line or third line after failure of Chryso or lorlatinib or anyone? I think okay, fine. We will go ahead in the third row.
Randeep, I just wanted to say that entrectinib is available on compassionate basis for ROS1 with brain mets.
Yes.
So just FYI.
Yes. No, thanks. Yes, it is available for ROS1 as well as for NTRK mutations if you have. Yes. Thank you, ma'am. Now we go to the third one, which is, I mean, this was absolutely new and I was aware of this mutation till I went through it and realized the importance of this. There are two papers which are presented in this. One was, this is a trial registry, which is very good paper of NRG. Around 110 patients have been there of NRG lung cancer, though it was both metastatic and early lung cancer in this. And the second was about case series of 6 patients on afatinib. And NRG has been discussed by the previous speakers, that what is NRG and how do we detect. Just comments, we have 10 minutes for this point. Anyone can comment. I think this is from the house. When to think about NRG? I mean, like we used to talk about EGFR, ALK, ROS, MET. And I mean, it is an ever-ending list, and there is too much of enthusiasm for the medical oncologist in lung cancer.
I think we can consider NRG1 in invasive mucinous cases, and in sometimes
yes,
even
that is the first point. I think invasive mucinous we shall always think, yes.
And even in non-mucinous cases also we can think. And PDL1 less than 1% we can think.
I mean, yes, that is characteristic that PDL1 is less. And it was actually very interesting. If you go through this paper, this is a chart which I thought I will reiterate, also presented by the speaker. I mean, among all the driver mutations, this is having the lowest TMB. I mean, there is absolutely no tumor mutation burden in this driver mutation positive lung cancer. And so both the TMB and PDL1 gives you the hint that we shall never use immunotherapy even in the later lines if you have NRG positive. It in the 110 paper series, it was equal presentation. I mean, 41% were males and 55 or 60% were females. I think sex will be not the differentiating criteria for this type of driver mutation, though slightly female preponderance is there. And majorly there is intrathoracic metastasis. Diagnostic tests, I mean, if you are really thinking, suppose you have a mucinous adenocea tomorrow, or you have a PDL10, and the scenario fits in because this is a rare mutation, this is not a common, and we are sending NGS. So, what is the best diagnostic test for NRG as of today, as per the availability of the experience? Anyone can take it. I mean, there is a chart. This is from one of the oncology, I mean, the annals paper. I'm so sorry to miss the reference, but you have the authors here. As well as it was there discussed in the discussion also of this registry that the NGS is best and RNA-based NGS are best as far as the chances of detecting this tumor is right. Though DNA-based NGS also you may get NRG mutations, but the best is a RNA-based NGS, and I think most of us, when we order a broad-based NGS, and we are covering the fusions such as ALK and ROS, we are basically dealing more on RNA-based sequencing for our lung cancer patients, and this must be covered. But to be frank, I will now start looking to the labs affiliated with me because we are generally outsourcing it to check whether they are checking for NRG1, and that is what is the learning that the panels to which we are, if it is not done in-house and we are outsourcing, we need to check in whether they are covering NRG or not. Like we have checked NTRK when the drug became available or the compassionate access became available to it. Okay, how will we treat? Suppose we have an NRG1 today. I think there was, these were the two presentations. The first was from the trial registry, and the second one was a case series. I think if you see the response rates, if you see the response rate CRPR combined is I think afatinib, which is there around in the last column, is showing some partial responses, and then chemotherapy is also showing some partial responses. But overall, if you see the PFS, it is actually very bad. Whether we talk about afatinib or chemotherapy or immunotherapy or anything, I think to my mind, this is a very discouraging PFS of 3 to 4 or 5 months for a driver mutation positive lung cancer. And maybe we are not using the right drug. Though the afatinib space series, there were 1 or 2 responses which were really good. And I think we have to learn what is the fusion partner. Like the series, the patient which did very well in the series was, I think the CD74 was the fusion partner. NRG has around 10 to 12 fusion partners. So I think it is more to be exciting time, and we need to learn a lot about this mutation. Now coming to this chart, how would you like to treat? And that is what I would like to ask the panelists, that how would anyone would like to treat if by chance they have sent a broad panel which covers NRG? Would you like to start with chemo, or would you put them on afatinib, because that are the two drugs which are available to us as of now? These monoclonal antibodies are not available to us, the ones which are mentioned in the last. Yes,
yeah. So actually, I mean, whatever data is there, it's not a randomized trial. It's showing the use of both the drugs. I would actually, I mean, so off the track, when like we can combine both the things, because it doesn't give second line. It's only 3 months survival.
But you will combine afatinib with chemo, which is bit risky. If it would have been a gefitinib data, I would have been very happy to do it.
You don't have second chance, Randeep, in this thing. 3 months of survival. You're going to use it within 6 months. Within 4 months, you're going to use both the drugs. Or chemotherapy also, you'll use afatinib also.
Point well taken. So you would like to combine afatinib with chemo.
There's no data. I'm quoting something.
I agree. No, I'm not questioning the data here. This is a very new. Vinayak, I'm not questioning the data here. What I was questioning you was about the tolerability, because I have combined. I mean, we know the data. Rita ma'am is there of gefitinib with chemo or erlotinib with chemo. But have you combined afatinib with chemo ever? Because afatinib has slightly. I mean,
afatinib is not a good drug. I mean, I agree with it. It's very stormy. I would look closely in any other molecules I studied. First thing is I'm going to do that. If the choice is afatinib and something else better than that, would be ideal. But I don't think, as you pointed rightly, the PF is so short, we not got it right.
And it is very odd for a driver mutation positive lung cancer. I mean, if I leave my EGFR like this, I am sure that maybe 3 months, 4 months, I mean, we 5, 6 months average, they keep on progressing with some mild progression, and we keep on continuing the same drug for EGFR, ROS, and sometimes with ALK also. Anyone else would like to comment and help us out? Suppose tomorrow this pops up in the report, NRG positive, with the current discussions happening in the two papers. How would you like to treat? Vinayak has given his comment that yes, off the trial, off the record, he would like to give appendicitis chemo with it.
As you have, sir, as you have already told that the partner is very important, CD74 partner. If it is CD74, then I think avortinib is a good drug. If it is not CD74, then chemotherapy should be used. What I derive from the discussion.
Yeah, I just
Fine,
request to
thank-
finish in next 2 minutes. So, yeah.
No, no, finish. This is last slide. You can finish now. Any comments from the panelists or from the house? This was my last slide. I mean, anyone, Vijay, Vinita ma'am, or anyone can, we have 1 or 2
Kumar
minutes.
sir is there, so I think.
Kumar sir is there, sir.
Thank you, Randeep. It was really nice. It was, I learned a
We
lot.
want-
Thank you.
No, no, sir. Thank you, sir. I think any comments from your side, please. We have a minute, and anything is not there in the chat box, I will stop the sharing. Yes.
No, no, I was discussing with Vijay about it, that we need to have this multiple times to understand the whole aspect. The problem is that so many information keeps coming. For example, EGFR only so many information comes, those uncommon mutations, then combinations. Now in the meantime, you have HER3, you have a drug for it. Now you have NRG, and again looks like you have a drug for it. And then by the time you have the repeat biopsy and then mutations. Was having a discussion that for this we should have a separate, so that people can digest it well. But it was very interesting. Thank you.
Thank you, sir. Thanks. I also learned a lot, and thank you. Over to the organizers.